Today, we are really excited to have Tara Marshall back with us. She's fantastic. She's been before, but she's come here to provide an update. And it's really around some of this innovative developmental stuff that actually makes a difference to patients on the front line. And it's about how we use some of that technology to deliver really positive experiences. So I'm going to let you talk about it in more detail, Tara, and share your story, and then we'll any questions, put them in the chat or in the Q&A. But thank you for coming along today, Tara. It's fantastic to have you with us again. So over to you.
Fabulous. And as always, it's absolutely delightful to be here. I've got quite a busy slide deck for you because this is our third visit here. So when we started, we introduced this as a pilot, and we've now scaled this and now worked around sustain on and what is a very tiny budget in many ways, and it's very much aligns with what Joe was talking about in how do you make money stretch as far as you can with and change those resources so we can maximize the impact but also maximize the spend at the same time, so that we get better value or value-based behaviors at the back end of this. So before we start, I just want to very quickly ask you, when we think about proactive care, and this is a connected care program is all about proactive care and prevention, what would you say would be the first word that would come to mind if I said to you, what is proactive care? We might have to have a word cloud in there for that. You've all got Mentimeter.
I've just dropped the link in the chat to Menti.
Fab. Sorry,
and just while people are kind of logging into it, I'll get the Menti slide up. So let's get that on the screen.
Oh, let's have a look. Yeah, I like prevention. Like crisis. Yes.
Patient-centered is nice.
Yeah. I think we've, in 3 years, it is really transitioned, I think, from where we were 3 years ago when we asked this kind of question, is who's in the room was one of them. But we'll talk about who's in the room as we start going through this. And I love understanding. Fabulous. That's fabulous. No wrong door.
I'm not clear on that one. Is that something you understand, Tara, or do we need some?
Sort of. Yeah. When you step outside that NHS door, those doors are very different. And like end to end, cradle to grave, all of those analogies are there. Oh, fabulous. Oh, I'm excited, more excited now to be telling you all about this. Yes. Right, I'll let you carry on doing that in the chat. Well, should we carry on back to the slides?
Yeah.
Fab. Can you see them or can I? Me. There we go.
That's it.
There we are.
Yeah. Okay.
So this is a programme and it's called LLR because it's Leicester, Leicestershire and Rutland. So we're sat in the middle. It's between the 3 local authorities, but funded by the ICB. And it's been very different in the way that it's been delivered and funded through that way. So it's through the Better Care Fund. And together, between all of us, we are working to improve the lives of people living in care homes by bringing their voices from the back of the room to the front. And that was that door opening bit that I really enjoyed, whoever it was that put that in the chat. But essentially, it's utilises telehealth. Now, people will recognise the virtual ward from your NHS colleagues in the room. Telehealth is slightly different to that in that it isn't clinician led, but they are boxes that we can put 30 people on instead of one box per person. So if you think about cost, it already starts to tick some of the boxes. Is it good value for money? We've deliberately placed them and focused on care homes because we wanted to manage the data. And one of our key drivers for this is Emma Jane Hollands. Without her, none of this would have happened, really, because the local authorities are leading this. We're supporting them to do it, and we've taken on board a lot more jobs as that transition and the ICB changes came into play. But also we've now got, working down the line, we'll have the devolution of our local authorities. So we'll go ICB already in changes, and some of them are in complete chaos, but all of those teams have essentially changed, and then our local authority teams will change. And yet that is where our care homes first and foremost report into, because those beds are commissioned by the local authorities, so they have a big impact in how this works. And when we think about the programme, we had to find a common language that everybody used across the NHS. And the only one that we could find was News 2, when we think about how we're worried and concerned about people. So telehealth is a device, and we'll go a bit more into that. But for this programme, we use the Whizzam Blue boxes, and essentially every piece of equipment in there is Bluetooth enabled. So it reduces all the usual transcribing errors. So we started with this as our aim. Wouldn't it be amazing if everybody that was worried about a person could hand over information clearly and confidently, be understood and heard? And that sounds really easy if you're in an ED department or you're handing over at the ward at the end of the day. When you start to do this in social care, we have to get that language across. This is just LLR across 55,000 staff, one ICB with 3 local authorities, 2 trusts, 3 hospitals, some more community hospitals, 2 different response services plus your wraparound services, and all of your GPs. And for our care homes, 70% of them nationally are residential homes. So the homes that we trained over COVID with News 2 were focused on the care homes with nursing. So this is a group that are already not getting an equitable training for learning about News 2. And in there was 9,000 residents. And those wraparound services change often depending on the funding that comes down from the local council to support them. And like other projects, it's often a year, 2 years. So those change rapidly. And remember, this is a 3-year programme. So a lot of our challenges didn't happen in year 1. A lot of our challenges happened in years, the end of year 2 to year 3, is how do we make it stick? Because we've made a change, but we now need to make it stick. So today we're going to talk about the whole of the 3 years and where we started. And we knew right at the beginning of this that we could only spend the money once. There was no way we could go back to the local authority and say, we need extra money. So we had to make it work. Otherwise, it became that traditional year-long project that fell over in year 2. So in year 3, we focused on embedding the use of it. And it's a bit like peeling an onion when we started in the pilot, is understanding who was where. By the end of year 3, we still had to unpeel that onion, but put the layers back on so we could align them with those wraparound services. And this is the timeline for it. So this is only just finished year 3. So we started in 2023 with a very small pilot with 20 people in it. And pilots are great, but everybody does pilots. We're really good at pilots now. But what we wanted to do is make sure that we could scale that pilot early. So we did a really early intervention at between months 4 and 6, and did a rapid evaluation and said, actually, are we in the right place? Is it working? Because we put boxes in Rutland, Leicester and County. And it's quite a big area to get across. If I drive across it, it's an hour and a half in my car, and I'm somewhere in the middle. So you can imagine just how big it is. And those homes that were using those boxes were essentially in their own little silo. They were already up against it, because one bit of bad press that came through the door with why are you doing this differently to the person next door encouraged that person not to put it on the shelf, essentially, because for them, they were the only ones doing it and sticking their head above the parapet. So we very quickly knew that we needed to build a community around them. And that happened organically. We didn't push this on people. We wanted to work with the willing. And this is how we found this scale to happen. So we don't lack strategy in the NHS, and I'm sure all of you that have been through the new recent changes, there's strategies, documents coming from everywhere. But actually, do we really change? Because sometimes that memory goes with us. That team that did a really good thing in their transformation have now disappeared, and nobody knows where that document is that went with them. And we often don't leave a legacy. We don't do succession planning very well in the NHS and legacy planning. What we do is we shift somewhere and consider it done, and then forget to do that end bit of it. And what we wanted to do was create a new habit and look at prevention and think about how we could do news to enable that to happen. And of course, on top of that, we have got the 10-year policy. So for us, it's about managing deterioration proactively. If we're going to move from sickness to prevention, we've got to be able to see it coming. We need to be thinking about how can we enable compassionate communities, and there are loads of compassionate communities out there, and they are absolutely brilliant in what all of them do. So do tap into anyone that is near you. And for the analog to digital, it wasn't necessarily here's a new digital project. It was where can we add the most value with it? Who can use it and maximize the ability to use this box? And make sure that we were still impacting people and the people around them. And when we think about a digital divide, this is where it comes a really big risk, because healthcare moves into the digital era quite quickly, because we can put a policy down through the NHS and it filters down. It doesn't do the same in social care. There's 5,500 different providers of care homes across England, and putting one policy across there is nigh on impossible. Everybody wants a slight change to it, a bit like you have a slight change to the policies that go down through the NHS, but it takes a lot longer. You have to then negotiate this with every single providing organisation that's out there. And what happens is the people that are enabled and often able to use digital devices is great. They're worried well, they're digitally enabled, and we're starting to challenge GPs around how we use those devices and the information that's on them. But then there's another group that aren't connected to digital, and that is the group that potentially deteriorate unnoticed. And this is Malcolm, so we can all wave Malcolm by in the future. He's in the rest of the slides, so don't worry about him, he's not dead yet, but he is there. But this isn't about treating illness, it's making sure that everybody has the chance to stay well where they are. And they are noticed through using digital equipment to do that. So how did we connect the whole system together? System 1 is, and EMIS is probably the biggest system. It's probably the biggest system across the NHS. But again, news flows through it. And we've set this up in the same as the peer framework. So that's the underpinning framework for the National Deterioration Programme. And that is prevention, identification, escalation and response. And you'll see through the slides, there are different colours going through this. But essentially, everything that's in the green is our opportunity to make a difference. That's our opportunity to prevent, intervene, make decisions and buy time. And we can do that because we know about deterioration early. We can't do that if we can't hear what people are telling us. So this programme is not just about a digital solution, it's also about that verbal conversation. In orange, we can start to think about who can we get in our wraparound services to support those people living in our residential homes. But by the time we get to red, that opportunity has passed us by. The bonus of having Bluetooth enabled equipment is translation error. Those charts are standardized across the NHS, but they can also be quite difficult to interpret when they've got dots, crosses, X's on them, arrows, and you can't read the tiny little signature box that's on there. So what digital does is allow us to have that digital signature and that complete audit trail. And we were really ambitious, but also knew that not every home was going to have one, because we can't push this out. This is again about working with the willing. But we had funding for 25% of the homes, and there's just under 300 homes across Leicester, Leicestershire and Rutland. So we wanted to pull together all of those quality improvement ambitions into this programme. And by working with the willing, we reached 37% at the end of it. But as I come from the NHS, I'm now director of These Hands Academy, and we founded this academy just under 4 years ago now. We moved from sitting inside this jar to sitting outside the jar looking in, and this is where social care are working with healthcare at the same time. And a lot of our providers felt it very much the same way. They got a scoring system, but they just weren't being heard. And I'm just going to pop into another question for you now. And the jars are depicting something all the way through, so check out the lids on them as we go through this. But as we worked along providers, we really did realise that actually they're still not being heard, didn't matter how much they knocked on that window. So how could we make that happen? And we still had an awful lot of work to do. So Jo, I will hand this over to you for the next Mentimeter question.
Fantastic, Tara, and I love the jars, by the way, the jar people.
Jar people.
Jar people. So what limits system transformation today? Rank in order of impact. So it'd be really interesting to see what people think about this. So hopefully people have still got your Menti open. There's another couple of questions after this one, so do put your thoughts in. So we've got options around workforce capacity, fragmented data, organisational silos, funding models, digital maturity, clinical engagement. Oh, they've moved around now. Public expectations and leadership alignment, I think, was the last one before they started to move. But all important, I'd say. So yeah, that's a challenge. How do you rank them? So first your responses in. See what everybody else thinks. So leadership alignment and organisational silos are not an unsurprising elements up there. See if those move around a bit. Heard of the responses in so far? Yeah, organisational silos, staying up there for now. Give it another moment to see if anybody's just finishing off getting it in order. You have to go with your gut.
Yeah,
so
no, go with your gut, folks. Don't think too hard about it. Go with your gut.
Yeah, I'm with Catherine. Surprise funding models isn't higher.
I think this is a reflection of where we are today. Because last year it was all about funding models.
Yes, which is why it's important to come back, because the landscape and the the zeitgeist changes, doesn't it? So, you know, what we're facing now with things going on. So Paul has added in, I would add another that perhaps causes the organisational silos, operational performance reporting and monitoring both internally and at NHSE and RO levels. Yeah, I don't think it adds value to that partnership or local or regional approach to things, or community-based approach, if everybody is judged individually on their performance. Because it twangs everybody back to, well, actually, I need to take care of my own rankings and ratings.
It certainly plays into what we do as what is now essentially sitting outside that wall. You know, how do we align our reporting with what the NHS want to see reported is the other thing. So that can be a challenge in there.
Absolutely. So Tara, what do you think then in terms of the results? What you expected, or have things moved
Sort
on?
of. I think things have moved. I think funding was a big issue. Last year we talked a lot about funding models, and now I think our focus is on it's the current climate that we're working in is these organisational silos, because I think people are trying to protect themselves with the current changes that are happening, and quite rightly that's what you're going to do. But I think that impact on how we're now thinking around funding models and what seems to be important to us around projects like this is different, and that's where it changes, and that's where it absolutely challenges the sustain layer of how do we keep some of these projects running and turn them into business as usual when we know we've got all these changes impacting that business as usual. And that's where this comes really into the end of it. Yeah,
and it's not surprising then, the workforce capacity has worked its way up to number 2 in the list, given the cuts going on at every level at the moment. Yeah.
I am a little bit disappointed that we've got public expectations at the bottom, but I think that's where we are today. And that's the bit that probably one of the reasons why I've stayed out of the NHS at the minute, and because for us that is our focus. That public expectation is what can we do to support the NHS to improve the public's experience of what we're doing.
I think in terms of, you know, what's going on at the moment, my view on that would be that with so much internal disruption, everybody's looking internally because it's impacting them, their team, their function, and therefore there isn't the ability to look externally whilst looking internally. I think that public expectation and outward looking is a consequence of being in a stable environment, that you don't need to worry about what's going on internally. You're just out there doing the bit out there. So I think that's probably reflecting that from my perspective. But other thoughts in the chat, do put your thoughts in.
Yeah, get involved, folks. This is an interactive session.
Yeah.
All right, I'll go back to the slides. There we go. So we'll leave the lady with the jar. And so first year, so pilot, everybody's excited about a pilot. We've talked already about how people were isolated in that pilot in many ways, but they also get a lot of support because we all want pilots to go really well, and we use that rapid evaluation to absolutely think about how we would scale to next steps. And actually, were we doing the right thing? Were they in the right places? This is the first time we put them into residential homes, and because we could put up to 40 people onto one of those boxes, we very rapidly got 800 people in there in the system that we could start thinking about and talking to. And we had a massive stakeholder list as well, because we were outside those walls of the NHS. So we got our providers, and the 20 homes all weren't from one provider. They were from different providers. So again, they had different ways that they would feed back to us. And we spread them out, which was great, but it sort of did limit our information a little bit. But this was the start of, for some people, it was the start of their digital journey. So we had to develop a checklist that everybody could fill in, that we could create and have enough information so we knew if we wanted to interface that system with, would we get into challenges with it. What we didn't want to do is take a phone call from a care home and go, oh, hang on a minute, I'll come back to you in 2 days when I've worked out how it happens. So that readiness checklist also thought about emergency preparedness if that box didn't work. Now, we've never had one not work, but there's always a possibility that something might happen. They might have dropped it. And some homes had more than one, which was great. Some homes only had one box. So if that box was broken, we needed to make sure that they could still use the news score and still have that verbal voice to escalate those worries and concerns. They all went through admin training with Wazan, and then they came through clinical training with us, and that was about proactively managing deterioration with the use of that box as well. And for the first time, we've been able to sort of think about what can we do with the data? How can we pull that data out? And how can we think about, can we do that differently? So we had thousands of observations in there. But we also knew that there was a weekly ward round. How could we support that weekly ward round? And on a lot of these systems and the electronic health records now, they can rag rate a dashboard for each care home. So the News 2 score helps them to rag rate those on the dashboard, which in turn helps the weekly ward round or any therapy team that's coming in, plus a manager that's perhaps not on the floor every day. They can see a bird's eye view of what's going on in their home very quickly. And again, this is learning all the way through. So we were always going back and asking people. And one of the things we knew straight away that it started to help a conversation. It started to help that I'm worried about somebody, not just because it's a long sentence. It's I'm worried about somebody and this is their news score. It turns those long sentences into numbers. We knew that it saved in year 1 about 2.5 hours on the phone waiting for GP referrals, and we knew that it reduced admissions. I mean, 100 in the first year with such a small amount of boxes was huge, and we expected as we scaled to go a little bit exactly that, to keep on that trajectory. And we wanted to tell more people about it, so we went and made a film, and this was our wow moment. And I will play this film for you. Unfortunately, it won't pop out, but hopefully you can all hear it. There you go. So we also, sorry, I'll let it finish in a minute. So we took that also to HSJ Awards, and Chris used to ring 111 several times a day. He got his own phone. He knew how to use it and he used it very well. And within about 6 months, that behaviour had stopped. We got a box. He was supported how to use it, and he was out sailing. And I'm pretty sure the people at 111 probably missed him for a little bit, but I'm pretty also sure that he's out doing his own thing, and that's perfect. So by the end of Chris's film and the HSJ Awards, we won another £150,000 to put 40 more boxes in 40 more places. And this is where essentially where the next Mentimeter question comes in, which is about who should lead the integration. So we're starting to pull people into our jar now. Who should lead integration across health and social care?
If you think of another option, put it in the chat. See if others vote on it.
Loving it. Fabulous. Well, let's go with the shared leadership model. And I shall crack on. Yeah, it's the most popular. So we'll talk about that one as we go through. And I'm just going to swap back to the other slides. There we go. So we're starting to bring some people into the jar. We're thinking about rapidly scaling this, and Chris's film went out across some of our learning disability networks, and about 50% of our homes now are with people with learning disabilities or in supported living. They absolutely couldn't get it off the shelves quick enough, because they felt pretty much not abandoned by the NHS, but they only had one annual health check. So this really helped support them, and procedural anxiety. So people could get used to this equipment in their own homes. They could do it in their own space, in their own time, and it equally helped the annual health check. So we set some KPIs in how we managed homes doing it and how we could support them. So we brought in an extra person to do the contact via email, the callings, the offer another intervention. They keep badgering them really to keep them in use, and changing from that reactive position to that habit forming. We talked to every single wraparound service we could. We kept talking to EMAS, we kept talking to the ICB. We had the care home subgroup, which was a great format to get our information out to those responsive teams. And with at the end of the year, we've got again thousands of observations, and we'd created several different dashboards for them. But the average news too in our residential care homes was between 3 and 4. Now, on a normal discharge pathway, that would keep you in hospital. So we started to think, how can we use this with our discharge teams as well? Because we've already got the virtual ward, and we didn't want to compete with the virtual ward. But what we wanted to do is enable people to still flow out of hospitals at the same time. And for our supported living homes, it became a very different story. Their average score was pretty much the same as you and I. They were fit, healthy adults with an average score between 0 and 2. But when they did fall off their perch, they fell off very quickly to a new score of 7. And that would potentially put them into hospital. And we have a couple of homes within our patch that have some really poorly people in them with long-term conditions, and they began to be able to manage those more effectively with their clinical teams and enable people to stay where they are. Because if you think about the amount of people that go to an emergency department and get turned around and come back, and there are those groups with learning disabilities that this happens to, because when they escalate those worries and concerns, that's the advice that they're given. That minibus that takes them then stops everybody else from going from their activity. It's also a pull on the team. We've had several stories now of periods of isolation in homes, from a flu outbreak to a C. difficile outbreak to all sorts of different outbreaks, where we can keep people where they are within their own home and have that outside support access them through that telehealth system, which has been really good for them and absolutely changed the dynamics of the home. We got our universities involved in it, but we didn't take the homes to our universities in a normal workshop. We took the university to our homes, because they haven't got the time to give up to do this, but we do want them involved in it, and they want to get involved in it. So we shifted the model there too. And we also had an opportunity to talk to a university in Canada, where we could start to think about the commonalities in their patch as well around their underserved communities, and produced a paper. But we kept talking to people, and we kept talking to them through every single year. We went back and said, what does it do for you? And it's been a really iterative process. We've learned along the way. We've enabled change along the way. We've reduced the disparities across the system, but we've also increased the equity for those people living in those residential homes. So we came into the sustain year thinking, right, now what we're going to do, we've got all these homes, we've got to keep them going now. So we started to think about how could we do this using our traditional quality improvement methodology, and published Pilot to Scale. And that refined the onboarding system. We had a green scheme where we could rehome the boxes. So go back to those KPIs, and if somebody hadn't used it for 6 months, we were contacting that home saying, how can we rehome this somewhere else? Because if you're not going to use it, let's put it somewhere where it is useful. And we did have homes that rehomed them because they couldn't introduce them. Some of them already had a system in place, and there are 35 different electronic health records out there in social care, and not all of them interface or integrate within the other system. We've had providers override a manager's decision because it's a big organisation and we're doing this in one small place in Leicester. So it's another place to start thinking about, do we target providers first? And we had homes that wanted to help another home. We had a home that had a spare box and said, you know what, we're not using it. We can get away with 2, have that one for another home. So we did. And we've still got 94 homes now on the system. We know that the monthly usage is roughly between 30 and 35%. Now, traditionally, telehealth systems are used less than 5% because we use them reactively, and they're a bit like defibrillators in a community telephone box. Unless somebody's confident in the way that they're going to use it, it's not the first line of defense when they're worried about somebody. It's usually the second or third. So as soon as you switch it on, if it's not charged, your password doesn't work, the software's not up to date, it's not going to be used and it will set on the shelf. And that's not the tech's fault, that's the way we implement it. We also saw a big dip in our data around the middle of one of the years, and we worked out that actually some of the providers are starting to charge each other to interface with each other's equipment, and the equipment was still being used. It's just the digital interface of the equipment wasn't being used. So that was a little eye-opener in, hang on a minute, what's going on here? So we had to think about how we manage that as well. And that, I'm sure, will be a constant change as we move forward with using equipment like telehealth in spaces like this, because the providers will all start to think about how they're going to pay their bills too. And we wanted people to keep it in safe spaces and make sure that the whole team could use it. And that again grew over time, and we were starting to shift that dial now from the red admissions right to the greens part of that. How can we keep people at home? So we looked at the anomalies in there, and we went back to that 10-year plan. How do we manage deteriorating proactively? Well, we're starting to see that stable use of, or stable news really, of 3 to 4 and 2 to 3. And that's because people are using it 7 days a week now instead of once when somebody's unwell, which is where you see the 6s. We are starting to see that shift from crisis into prevention mode and see that impact on our out of hours service. And we see that in the data, whether it's taken for routine or whether it's taken for they're worried and concerned. And then we start to see that shift from I'm only worried about somebody to actually this is really good and I'm confident in using it because I'm using it routinely. And we know it's released time to care, but most importantly, staff are being heard in that jar. They are starting to be listened to within the system because we're all talking the same language. And that's the culture shift. And again, when we start to think about reducing variance, to me, this is where the magic really happens. And we start to see the increased use, the reduction in news, and the reduction in our services over time. So in a nutshell, our pilot focused on funding, but we had to be iterative. We had to lead it, but it also had to be sustainable. And that's where this part of it, that habit forming, that culture shift and behaviour change makes it sustainable. From a funding perspective, we didn't do the traditional license. These were licensed for 5 years. So it was allowed time. It was allowed time to learn, time to iterate, time to embed. And from the sustain bit, it's about how do we leave a legacy for the homes to still use it with all of the ICB changes going on, because they are all impacted by those changes. But we don't want their residents to be impacted by their changes of the ICB. We want them to still continue to use it. So these licenses are designed to go past those changes to 2028. So hopefully the system will have settled down and they're still in the same position that when they're worried about somebody, they can really start to have that conversation across the patch. Now, I'm going to perhaps miss the question out for this, but it is, and maybe put it in the chat, is which area is the most underinvested in for sustainable transformation? Because this is the jar without a lid on it. This is the jar when we start to think about community. And I've got another couple of slides that I want to fit in before we run out of time. And that was about keeping that sustainability piece up to date. But once we let that lid off the jar, we really start to become a community and start having that shared leadership and start having those projects running together. I'm very fortunate in my background and where I've come from, in the way that I've worked with the NHS, with the health innovation networks. I've led the managing deterioration programme for a long time from the health innovation networks and the patient safety collaboratives. So I've put all of that experience into this project, but that's also where all of your experience can help your community providers and that shared leadership coming together, because they know their area and yet you know yours too. And it's about bringing that together, brainstorming it and making it happen. So for us, what we left behind, a bigger part of this was around that sustained training. How do we keep that habit forming going when there is no national mandate for it? So there isn't mandatory training for News 2 in social care. There is in the NHS, but there isn't in social care. So we had to evolve that training as well and work with what was a team of one to a team of 5 by the end of it, to still manage 105 homes, or 94 at the end. And we set about doing the same training, managing deterioration proactively, but we went from that traditional training of here's a News 2 score, how do you do that, to why are we going to do that and how does this equipment work? So we did a lot around anatomy and physiology, a lot around what was the equipment reading. And what we found was the more we talked about this and the more we supported people to use it, the less repairs we were going to have to do. And people started looking after it. Nobody lost bits. And because it's Bluetooth enabled, you lose a bit because it's gone between floors in your pocket. And pockets are great things to put instruments in. They started to go back in the boxes, and in the boxes they were paired to. So people really started to think about and value that equipment on a much different level. We also started to do this right at the beginning by going into care homes. And we shifted this as all of a sudden we'd gone from 20 to 100. So we shift this into a virtual mode. Not only did it save us loads of miles, but it saved the care home providers that backfill. So we offer a lot of free training out in the NHS. And we go, oh, you go, some great free training. But the care home still doesn't get paid to backfill their staff. So we wanted to find a way that we could deliver this virtually. And the other thing that we employed in all of this was a simulated person. We found that if we went face to face, people would come back to us and say, oh, we're not confident. Can you come and show us again? Whereas in our virtual session, we had a simulated person in there. We could set off the alerts on that equipment. We could make it make funny noises. And they could do that in the confines of their own office in a safe space, not round the residents. And then they were comfortable when the alerts did go off later on, and then they could go back to that person, that simulated person, as many times as they wanted to, and that worked really well. In fact, I had a home only last week put me on their cinema screen. I mean, what a great place to be. They've got a cinema in there, but I was on that big screen with this simulated person, and that was an awful lot of fun, I can tell you that much. We then thought, how do we sustain this training? So we developed the usual e-learning package, but actually changed that into a refreshment package. So we brought in an animator, and you will see Maggie and Malcolm through all of these slides and in all of our videos. But we brought in an animator to remove us as clinicians from that training space into something that was relative to them. We used their stories to create the programs, and those stories went through the programs right from the beginning. And we set 3 up for them that they could access 365 days a year. We made videos, and of course they go to one place, they don't go to another place. So we created an e-library for everybody that could get into whatever we want to do. So anytime anybody joins our website, that e-library is there for anybody across England. But by year 3, 700 downloads had started of these books. So we thought, well, maybe we better put them all in the same place. And we can also do version control for them as well. And again, we went back to ask them, as we always do. Having News 2 made all the difference. You know, that it's great that we're hearing that. It's not new. News 2 isn't new. The technology isn't new. It's just putting a different angle on it and putting it into a different space to make it work. And as we're going through all of these changes, you know, this is what we have to think about. What have we got that we can use to the best of our ability? Hospitals are places where we decondition. If we can keep people in their own homes, we can reduce some of the costs for wraparound services that we have to provide as an NHS, but also reduce those admissions, those avoidable admissions, those trolley waits. And the first thing I was taught on my patient safety course, probably about 10, 11 years ago now, was the only way to save money in the NHS is to reduce the length of stay. We went back through some of the admission data, and we're in a very lucky position to be able to do this from outside that jar and look at that difference in length of stay. But you can do an awful lot in 14 days. But equally, that person can be mobile. They can be in that cinema, in that care home. They can go to the bar in that care home because they've got one, and they can do it under their own steam to get there. So it does relieve pressure, but most of all, it supports neighbourhoods to think about what happens next, because that news score enables the community, not just the NHS, to think what's different. And our communities are full of now confident voices. We want them to be full of confident voices. That's where we've got to get to if we're going to manage this 10-year plan. We need to engage families in it. We brought them to open days. We brought them to all different things to let our families know that these boxes were in those places, and our families loved them. They felt reassured that their relatives were being looked after. It's strengthened the relationships, but also facilitated that early decision making with our pharmacy teams and our GPs, and it kept people at home. So I'm just going to very quickly take you back to that. Wouldn't it be amazing? Yes, it would. Yes, it can, but it takes an awful lot of work to make that happen. And we've been recognised on the national stage and the international stage. But one of the things that got released last week was the Care England collaboration on their white paper. And it's been 6 months in the writing, but it's there now. And it absolutely encourages the use of News 2 proactively and uses that common language across all of the NHS and social care. So I know people are dropping stuff into the chat, but these are the other people that we work with. If it wasn't for Jo and her team, our 3-year story wouldn't be out with you, and it will be available on their YouTube channel. You know, we have tried to share this far and wide to make this change to go a lot further than LLR. They are their exemplar. They are the champions in this, and without them, it wouldn't be happening. But our job is also to tell that story, and we've done that through that Care England white paper. Please do come and see us, sign up, see the e-library. You'll find all of our resources there, and with Jo, because she's absolutely amazing for letting us come and talk to you again. And I will stop rattling on now and let Jo close.
So, Tara, again, just so inspirational. We've got just a couple of minutes. Does anybody have any questions for Tara? I imagine you've got lots because there's so much to unpack in that. But also, just congratulations and thank you for doing what you do, because I don't know about everybody else, but what I see there is I see people being treated as humans, whose quality of life, whose health, whose is being at the centre of it, and it just seemed amazing to me that being able to share their stories and designing it from their point of view and really doing what ultimately we should all be here to do.
Yeah, no, totally. And I have to say, with my old NHS hat on, I'd still be waiting on some of these project boards. So, in some ways, it's been nice sitting outside the glass, although it's been very hard. But we're here to help anybody else to do this. We want to enable the whole country to do it. So just come and give us a shout. We'll help you.
Absolutely.
And I this is about every resident that lives there.
And again, it's not, I mean, for how to do what you've done and how that can support people across the country in this kind of way, but also the approach that you've taken, that can be adapted to all sorts of different service improvements that can improve quality of life, but also really evidencing the health outcomes. Does anybody have any quick questions for Tara? Stick your hand up or put them in the chat. So Carl has put a question, do you know if this is already happening in Nottinghamshire?
I know Nottingham have a pilot running. They had a pilot running with, I think, 10 boxes a while ago, led by their clinical team. So shout if you need a hand, because if Leicester's got some, Nottingham's got some, Derby's got them, Lincoln have got them. The hardest part is keeping them in use, and that's the bit that we've tried to do differently.
Yeah, that's a great question. So do connect, Carl. If you have a name, please let me know. So we've got your details, Tara. Yeah, drop an email, and yeah, should be happy to connect up. Because I think the other thing then is the most difficult thing is getting spread and adoption, and it's the sustainability. What I was really interested in what you were saying about the rehoming scheme. Because so often tech gets thrown out there and it's forgotten about, and it just sits gathering dust. But I love the fact that you were not just reusing it and recommissioning it. I'm interested in how do you actually how do you keep it maintained and replaced? Who does that? Where does that responsibility sit?
So it really often depends on who buys it, as to where that responsibility sits, and that's where it can get complicated, but it's something we need to think about. The reason we did the rehoming scheme, and we knew we focused on the licenses, so we could move a broken box, we could replace a broken box and move a license to that broken box. It's not something I'm sure every tech company will want to do, but Wizam were great and said, you know what, yeah, let's have a go. Because normally you'd buy a new box and a new license, but that license has still got 3 years on it. So let's think about the license, let's maximize that. And then, of course, we didn't tell homes that they couldn't rehome. We ran that rehoming scheme really nicely and basically said, if you haven't got one or you can't use it, that's fine. It's okay, you've tried. Then put it somewhere where you can be using it. And those homes, they just picked this up and just went with it. If we'd have done that in a different way, I think we'd have got a bit of resistance. If we'd have said to people, it's on a shelf, you need to get it off a shelf. But I've found them in some really weird places. I've found boxes in sheds before now, because they've had a change of manager. The workforce turns over a lot quicker in that space. So it's never always the fault of the home that's not being used. No. Perhaps the communication hasn't happened, that we're using it and we've got a new provider in and they don't want to use it. That's fine. Again, rehome it.
The sustainable training that goes with that was obviously an important part. I'm mindful we've run out of time. I'd be chatting for ages. Maybe we need to do a podcast where we get to explore some of those questions. But thank you everybody for coming along. Thank you so much, Tara, for sharing the journey that you've been on as you've gone through it.
As them.
So many lessons to learn and such great experience and great outcomes. Thank you for sharing. That's been fantastic. Quick hand of applause for Tara. Thank you, everybody.
Thank you for coming, everybody.